Welcome to Chapter 8. We're going to talk about pacemaker rhythms. A cardiac pacemaker is a battery-powered device that delivers an electrical current to the heart to stimulate depolarization. A pacemaker system consists of a pulse generator, which is the power source, and pacing leads. Pacemaker systems. There's a few different things that go into a pacemaker. So it's an implanted pacemaker will mimic the action of your natural electrical system, and the pacemaker is composed of two parts. The pulse generator, it's a small metal container that houses a battery and the electrical circuit that regulates the rate of electrical pulses sent to your heart. Second is the leads or electrodes. There is 1 to 3 flexible insulated wires placed in chambers of your heart and deliver the electrical pulses to adjust your heart rate. Pacemakers work only when needed. For example, if your heart rate is too slow, the pacemaker will send a signal to your heart to correct the beat. The site of implantation of a permanent pacemaker or implantable cardioverter defibrillator, the pacemaker is usually implanted in the left pectoral region, but it may be placed elsewhere if necessary. The pacemaker's pulse generator is usually implanted under local anesthetic into the subcutaneous tissue of the anterior chest, just below the right or left clavicle. The patient's handiness, occupation, and hobbies determine whether the pacemaker is implanted on the right or left side. An implantable cardioverter defibrillator is a small battery-powered device placed in your chest to monitor your heart rhythm and detect irregular heartbeats. These devices are capable of automatically delivering stage therapy and treating VTach, VFib, or arterial tachycardia. The pulse generator of a temporary pacemaker is located externally. Temporary pacing can be accomplished through transvenous, epicardial, or transcutaneous means. Transvenous pacemakers stimulate the endocardium of the right atrium or ventricle, or both, by means of an electrode introduced into a central vein such as the subclavian, femoral, brachial, internal jugular, or external jugular vein. Epicardial pacing is the placement of pacing leads directly into or through the epicardium. Epicardial leads may be used when a patient is undergoing cardiac surgery and the outer surface of the heart is easy to reach. Transcutaneous pacing, also called temporary external pacing or non-invasive pacing, is the use of an electrical stimulation through pacing pads positioned on a patient's torso to stimulate contraction of the heart. TCP is indicated for significant bradycardias that are unresponsive to atropine therapy or when atropine is not immediately available or indicated. It may also be used as a bridge until transvenous pacing can be accomplished or the cause of the bradycardia is reversed. This is an example of a monitor or defibrillator that provides cardiac monitoring, defibrillation, cardioversion, and transcutaneous pacing. The primary limitation of TCP is a patient's discomfort. That is proportional to the intensity of skeletal muscle contraction and the direct electrical stimulation of nerves. Because TCP is uncomfortable, the administration of sedatives or analgesics is usually necessary in responsive patients. Temporary transvenous pacing is indicated when prolonged TCP is needed. Here's a list of possible TCP complications: coughing, skin burns, interference with sensing, discomfort from electrical stimulation to the skin and muscles, failure to recognize that the pacemaker is not capturing, tissue damage including third-degree burns, and pacing threshold changes. Pacemaker lead systems may consist of single, double, or multiple leads. The exposed portion of the pacing lead is called an electrode, which is placed in direct contact with the heart. Pacing, which is also called pacemaker firing, occurs when the pacemaker's pulse generator delivers energy through the pacing electrode to the myocardium. Evidence of pacing can be seen as a vertical line or a spike on an ECG. Capture is the successful conduction of an artificial pacemaker impulse through the myocardium, resulting in depolarization. Capture is obtained after the pacemaker electrode is properly positioned in the heart. With 1-to-1 capture, each pacing stimulus results in depolarization of the appropriate chamber. On the ECG, evidence of the electrical capture can be seen as a pacemaker spike followed by an arterial or a ventricle complex. Depending on the cardiac chamber that is being paced, mechanical capture is assessed by palpating the patient's pulse or by observing right arterial pressure, left arterial pressure, or pulmonary artery or arterial pressure waveforms. This is an example of a temporary unipolar pacing lead. A unipolar electrode has one pacing electrode that is located at its distal tip. The negative electrode is in contact with the cardiac tissue, and the pulse generator that's located outside the heart functions as the positive electrode. The pacemaker spike produced by a unipolar lead system is often large because of the distance between the positive and negative electrode. Unipolar leads are less commonly used than bipolar lead systems because of the potential for pacing the chest wall muscles and the susceptible of the unipolar leads to electromagnetic interference. Example of a bipolar pacing lead. A bipolar lead system contains a positive and negative electrode at the distal tip of the pacing lead wire, which temporary transvenous pacemakers use as a bipolar lead system. A permanent pacemaker may either have a bipolar or unipolar lead system. Bipolar and unipolar pacing. The first box, A pacemaker spike produced by a bipolar lead system. In the second box, B, a pacemaker spike produced by a unipolar lead system. The pacemaker spike produced by a bipolar lead system is smaller than that of a unipolar system because of the shorter distance between the positive and negative electrodes. A pacemaker that paces a single heart chamber, either the atrium or ventricle, has one lead placed in the heart. This is an ECG of a single chamber pacemaker with arterial pacing spikes. Arterial pacing may be used when the SA node is diseased or damaged, but conduction through the AV junction and ventricles is normal. This type of pacemaker is ineffective if AV blocks develops because it cannot pace the ventricles. This is an ECG of a single-chambered pacemaker with ventricle pacing spikes. Ventricle pacing is accomplished by placing the pacing electrode in the right ventricle, which stimulates the ventricles and produces a pacemaker spike on the ECG, followed by a wide QRS, resembling the ventricular ectopic beat. The QRS complex is wide because a paced impulse does not follow the normal conduction pathway in the heart. A single chamber ventricle pacemaker can pace the ventricles, but it cannot coordinate pacing with the patient's arterial rate. This results in asynchronous contraction of the atrium and ventricle. Because of the loss of the AV conjunction, a ventricle demand pacemaker is rarely used in patients with an intact SA node. A ventricle demand pacemaker may be used for patients with chronic arterial fibrillation. Pacing leads in both the atrium and the ventricle enable a dual-chamber pacemaker, used to sense and pace in both heart chambers. A dual-chamber pacemaker uses two leads. One lead is placed in the right atrium and the other in the right ventricle. Dual-chamber pacing is also called physiologic pacing. A dual-chamber pacemaker stimulates the right atrium and the right ventricle. stimulating first the atrium and then the ventricle, mimicking the normal cardiac physiology and thus preserving the arterial contribution to ventricle filling. This is an ECG of a dual-chamber pacemaker with arterial pacing spikes and ventricle pacing spikes. A biventricle pacemaker has 3 leads, 1 lead for each ventricle and 1 lead for the right atrium. This device uses cardiac resynchronization therapy to restore normal stimulus to the ventricle contraction for patients with heart failure, thereby improving cardiac output and exercise tolerance. A fixed-rate pacemaker, also known as an asynchronous pacemaker, continuously discharges at a preset rate, usually 70 to 80 impulses per minute, regardless of the patient's heart rate or metabolic demands. An advantage of the fixed-rate pacemaker is its simple circuitry, reducing the risk of pacemaker failure. However, this type of pacemaker does not sense the patient's own cardiac rhythm. This may result in competition between the patient's cardiac rhythm and one of the pacemakers. Ventricle tachycardia or ventricle fibrillation may be induced if the patient's pacemaker were to fire during the T wave, which is a vulnerable period of a preceding patient beat. The fixed-rate pacemakers are not often used today. A demand pacemaker, also known as a synchronized or non-competitive pacemaker, discharges only when the patient's heart rate drops below the pacemaker base rate. For example, if the demand pacemaker was preset at a base rate of 70 impulses per minute, it would sense the patient's heart rate and allow electrical impulses to flow from the pacemaker through the pacing leads to stimulate the heart only when the rate fell below 70 beats per minute. Demand pacemakers can be programmable or non-programmable. The voltage level and impulse rate are preset at the time of manufacture in non-programmable pacemakers. Pacemaker codes are used to assist in identifying a pacemaker's programmable pacing, sensing, and response functions. The first letter of the code identifies the heart chamber or chambers paced. A pacemaker used to pace only a single chamber is represented by either an A for arterial or V for ventricle. A pacemaker capability for pacing both chambers is represented by a D, which means dual. The second letter identifies the chamber of the heart where patient-initiated electrical activity is sensed by the pacemaker. The third letter indicates how the pacemaker will respond when it senses patient-initiated electrical activity. The fourth letter identifies the availability of the rate, which is the pacemaker's ability to adapt its rate to meet the body's needs caused by increased physical activity and then increase or decrease the pacing rate accordingly. A pacemaker's rate capability may also be referred to as the rate responsiveness or rate adaptation. The fifth letter denotes multi-set pacing, biventricle pacing, or more than one pacing site in one ventricle. Although the use of all 5 letters is sometimes needed for completeness, the first 3 letters are always required. During the refractory period, a ventricle demand pacemaker does not sense any electrical activity. The refractory period is followed by the alert period. If no QRS complex is sensed by the end of the alert period, the pacemaker fires and stimulates the ventricle depolarization at a preset rate. The ventricle demand pacemaker is a common type of pacemaker. With this device, the pacemaker electrode is placed in the right ventricle. The ventricle is sensed and the pacemaker is inhibited when spontaneous ventricle depolarization occurs within a preset interval. When spontaneous ventricle depolarization does not occur within the preset interval, the pacemaker fires and stimulates ventricle depolarization at a preset rate. P waves can appear anywhere in the cardiac cycle and have no relationship with the QRS complex because a ventricle demand pacemaker does not sense or pace arterial activity. A disadvantage of ventricular demand pacing is its fixed rate regardless of the patient's level of physical activity. A dual-chamber pacemaker senses and paces in both the atria and ventricles. The pacemaker emits a stimulus spike whenever a P wave or QRS complex is not sensed with some programmed time interval. A dual-chamber pacemaker may also be called a DDD pacemaker, indicating that both the atrium and ventricle are paced. Both chambers are sensed, and the pacemaker is both a triggered and inhibited mode of response. The presence of a DDD pacemaker does not necessarily mean the pacemaker is in DDD mode. DDD pacemakers can be programmed to different modes depending on the patient's need. The development of chronic arterial fibrillation, for example. Here's another chart for defibrillator codes. Pacemaker malfunction. When a pacemaker fails to pace, also referred to as failure to fire or failure of pulse generator, is a pacemaker malfunction that occurs when the pacemaker fails to deliver an electrical stimulus at its programmed time. When a pacemaker fails to pace, it is recognized on an ECG as an absence of a pacemaker spike. Even though the patient's rate is less than that of the pacemaker and a return of the underlying rhythm for which pacing was initiated. Patients will have signs and symptoms. Those may include bradycardia, chest discomfort, and hypotension. This is all failure to pace and why it might happen. Treatment may include adjusting the sensitivity setting, replacing the pulse generator battery, replacing the pacing lead, or replacing the pulse generator unit, tightening connections between the pacing lead and pulse generator, or removing the source of electromagnetic interference. Failure to capture is the inability of the artificial pacemaker stimulus to depolarize the myocardium and is recognized on the ECG by visible pacemaker spikes not followed by the P waves. If the electrode is located in the atrium, or a QRS complex if the electrode is located in the right ventricle. Patient signs and symptoms may include bradycardia, fatigue, and hypotension. This is some causes of failure to capture and also reasons why it might happen. So if the problem is a result of low output energy, slowly increasing the output energy until capture occurs may resolve the problem, which just means that the setting that it's set at might be too low. They might have to make it higher. With transvenous pacing, repositioning the patient to the left side may promote the contact of transvenous pacing lead with the endocardium and septum. Sensitivity is the extent to which an artificial pacemaker recognizes cardiac electrical activity. Undersensing occurs when the artificial pacemaker fails to recognize spontaneous myocardial depolarization, and it is recognized on the ECG by pacemaker spikes that occur within P waves, pacemaker spikes that follow too closely behind the patient's QRS complex, or pacemaker spikes that appear within the T waves. Because pacemaker spikes occur when they should not, this type of pacemaker malfunction may result in pacemaker spikes that fall on T waves. Competition between the pacemaker and the patient's own cardiac rhythm, or both. The patient may complain of palpitations or skipped beats. This is an example of undersensing. Oversensing is a pacemaker malfunction that results from inappropriate sensing of extra electrical signals. Arterial sensing pacemakers may inappropriately sense ventricle activity. Ventricle sensing pacemakers may misidentify a tall peaked T wave as a QRS complex. Oversensing is recognized on the ECG. A pacemaker spike at a rate slower than the pacemaker preset rate, or no pace beats even though the pacemaker preset rate is greater than the patient's rate. So this is an example of oversensing. This is some causes of failure to sense. Treatment for undersensing may include increasing the sensitivity setting, replacing the pulse generator battery, or replacing or repositioning the pacing lead. Treatment for oversensing may include adjustment of the pacemaker sensitivity setting or possible insertion of a bipolar lead if oversensing is caused by a unipolar lead dysfunction. This is for analyzing pacemaker function. You should identify the underlying rhythm and rate if possible. Is there evidence of arterial paced activity, ventricle paced activity, or both? Determine the rate and how regular of the paced interval. Compare the escape interval to the paced interval and analyze the rhythm strip for pacemaker malfunctions. Everything that we talked about, which is failure to pace, failure to capture, or failure to sense. So this is also part of analyzing the pacemaker function. It's just showing you that their underlying rhythm is sinus. They are not arterial paced, they are ventrically paced. The rate is 65 pulses per minute, which is regular. The pacemaker didn't malfunction and it looks correct to me. And so this would be considered sinus rhythm with a ventricular pacemaker at 100% capture at 65 pulses per minute.